Hi, everybody. Thank you so much for joining us today for this fireside chat titled YVI, Policy Opportunities and Obstacles Around Vision and Mental Wellness. My name is Jennifer Dexter. I'm the Vice President for Policy at the National Health Council. I will be your moderator today for this discussion. Today we're going to be talking about the policy obstacles and opportunities that exist within the vision and eye health and mental health wellness communities, and determine how both communities can work together to ensure patients facing vision loss are connected to the mental health care they need to maintain their well-being. I want to start out by introducing our awesome panelists for this session. The first is Sara Brown. She's the Director of Government Affairs at Prevent Blindness. And then we're also joined by Angela Kimball, and she is the Senior Vice President of Advocacy and Public Policy at Inseparable. Before we get into the discussion, a few housekeeping items I want to let you know about. The discussion will be recorded and made available on the Prevent Blindness website after the session. We will take questions from the audience and we'll respond to them as time allows, of course. If you want to have a question, please place it use the Q&A button at the bottom of your screen. So I want to start by really thanking our panelists for being here. I think this is going to be a really interesting discussion. And I want to start out with a broad question for both of you. So Sara, can you share the current policy landscape around vision? And Angela, can you share the policy landscape around mental wellness? Let's do a little table setting. So I'll start with you, Sara.
Sure. Thanks, Jennifer. And I'm very happy to be here. For my audio description, I am a light-skinned woman, although usually this time of year, I wish I was a little bit more tan. I have brownish hair. I'm wearing a blue shirt underneath a black blazer. So Jennifer, to answer your question, I think looking at the landscape of vision and eye health policy, I definitely feel very optimistic about the direction that we as a community are heading in. We're most certainly seeing consumers and increasingly lawmakers come around to the question that many of us in our space have been asking ourselves for years, which is, why is everything above the neck considered separate from healthcare? Why is it that we're excluding vital organs like our eyes and our brains and the structures that are used to interpret and process the world around us from conversations around access and health equity, and most certainly the costs of receiving care? I think this is because we're actually realizing that there are consequences when we leave vision and eye health out of the equation, and these consequences are becoming more and more apparent. As we increasingly link both vision and eye health to broader healthcare trends, such as chronic diseases, aging health, social determinants of health, and environmental factors around vision loss, childhood development, and most certainly mental health, as we're here to talk about today, we're starting to put the pieces together that it no longer makes sense to keep our eyes separated from healthcare. And it's hard to look at every single policy out there, such as adding vision or low vision device coverage to Medicare, addressing children's vision and eye health through school-based interventions or other system-based interventions of care, or telehealth policies, and say that we are where we want to go right now. But these conversations are happening, and they're happening at a larger scale. And I think while we still have a long way to go, conversations like the one we're having today still need to happen, and it's encouraging to see that they are happening. There are opportunities right now, I think, in front of us in areas, to specifically name a few, such as community-based programs, strategies for early detection and intervention of vision loss and connecting those folks to care, research and surveillance around prevalence and surrounding socioeconomic factors that can lead to disparities in eye health access and outcomes, ensuring a capable and adequate professional workforce that has the resources and the tools necessary to foster a system of care that meets the patient where they are on their eye care journey, as well as we're going to talk about today, their mental health care journey. And also addressing vision and eye health as a public health priority and not solely as something that is more of an individual problem.
Thank you, Sara. Angela, do you want to take it from your perspective?
Sure. Thank you so much. I will just share that, the policy landscape as it relates to mental wellness is really heavily shaped by the pandemic. The silver lining of sorts to the pandemic is that it challenged everyone's mental wellness. And as a result, there's an almost universal acknowledgement of mental health as an important and underaddressed issue in our country. Legislatures and even Congress, where it takes even longer for change to take hold, are holding hearings on mental health. They're making unprecedented investments in mental health. And really, we're hearing from the National Conference of State Legislatures that this is a top issue, mental health, for legislators. So that's an important piece of the context here. Another thing that happened during the pandemic is that telehealth took hold. And the biggest single increase in the use of telehealth services was specifically for mental health care, including audio only. And some of this is now at risk now that the official public health emergency is over. And so there's a lot of work to be done to make sure that telemental health care is covered permanently, including audio only. And I just want to say that audio only telemental health has some legislators skeptical. So this is really an area where awareness of how this can work for people with vision impairments could be incredibly valuable. I will add that mental health has made a lot of progress recently, but it started off from such a disadvantaged and marginalized position that there's really a long way to go. And I just want to throw out a couple examples. Medicare, which covers so many Americans, usually older adults, people with disabilities. It covers primarily in the mental health realm, something that we call in shorthand, docs, meds, and beds. So not an array of community-based interventions. There's been recent headway now. So Medicare will now cover mobile crisis response in mental health crises, but in a limited fashion that's going to need expansion. And Medicare limits the coverage of a lot of mental health providers, and many people don't know this. Just late last year, Medicare finally it became subject to legislation that allows for the coverage of licensed professional counselors and marriage and family therapists, and in some instances, peer support specialists. So one of the challenges in gaining access to care is that Medicare, one of the biggest coverage places in our country, hasn't covered the entire array of mental health providers. It's also not subject to federal parity law. So there's no requirement that Medicare actually covers mental health and addictions care on an equivalent basis to other medical care. On a positive note, there's change happening. And in Medicaid, which serves so many low-income Americans and particularly children, there's really a lot of proposed changes in rules to increase access to mental health care. And I'll end by saying that there's a lot of work happening at the state level. So recently, a couple states, Illinois and Delaware, passed legislation to make 1 or 2 annual mental health wellness visits covered as no-cost preventative services by commercial health plans. So to sum up, the landscape is really changing in a very, very positive direction. I'm here at the National Governors Association in a hotel room, and I did mention I'm wearing dark blue glasses, silver blonde hair, fair skinned, and in a hotel room. But the governors here have been talking very specifically about youth mental health. Not heard that ever before, that much knowledge and awareness and commitment to actually changing access to behavioral health care. But there's a long way to go before our healthcare systems catch up with Americans' changed perspectives and the increasing demand for mental health care.
Angela, I appreciate that. I know both National Council of State Legislatures and National Governors Associations are 2 places where a lot of change and information and education happens. So glad to see you're there. I forgot to do my visual introduction. I apologize. I am a middle-aged white woman in the brown hair and a ponytail, wearing a black and white shirt, sitting in front of a wall full of pictures and a couch. So I'm going to turn it back to you, Angela, talk a little bit around what are the biggest access challenges in the mental health world right now?
My gosh, in a word, everything. And I'll start with the obvious, which is workforce shortages. So people simply can't get appointments with behavioral health professionals very easily. And so in addition to Medicare, which I mentioned previously, Medicaid and private insurance are lagging in developing networks of mental health and substance use disorder providers. There's a lack of fair and equivalent coverage and the ability to provide an appropriate range of services. Frankly, in virtually every county in this country, there's a dearth of mental health and substance use professionals. HRSA, which is the Federal Health Resources Services Administration, actually tracks healthcare workforce shortage areas, including for psychiatrists, and notes that there are literally tens of thousands of additional behavioral health professionals needed. And that's not even counting the other range of mental health professionals who may not be licensed that are needed to deliver care. And just like in any part of our economy, shortages lead to disruptions in the delivery of care. It's also led to a lot of professionals not even taking commercial insurance because there's so much demand that they can basically make a living with cash only practices. And so that leaves mental health care out of the reach for far too many. I'll speak now about another access challenge, and that's the insurance restrictions. So how commercial insurance and Medicare and Medicaid cover and pay for mental health services really affects access to care. As the old saying goes, if it's not paid for, it isn't happening. And what we know from research into claims by commercial insurers covering literally millions of people is that psychiatrists are paid on average about 20% less than physicians. And they're the relatively well-paid mental health professionals. In Alabama, a community mental health professional with a master's degree makes significantly less than a public school teacher with a bachelor's degree. So that is contributing, that inequity and sort of payment parity is contributing to a lack of access. And then on top of that, insurers are creating even more barriers by flatly denying services that treatment professionals recommend without providing effective alternatives. So I'll stop there on the insurance coverage. And the last thing I'll say is that one of the most important ways to increase access is to actually integrate mental health care into primary and specialty care settings. That's where people are. Yet the financial incentives are lacking for that integrated and coordinated care. And of course, while awareness of mental health is rising, the awareness of co-occurring disorders is not there yet. So treatment professionals often view health challenges singularly, which results in unrecognized and untreated mental health conditions when people have a primary condition that's something different. So I think that's another piece in terms of the access, is that people are really just not thinking of us as whole human beings that have a multitude of conditions at any given time.
That's excellent. Thank you, Angela. So I'm going to ask you the same question from the vision advocacy perspective. What are the greatest barriers to access right now?
Well, thanks, Jennifer. While Angela was speaking, I was writing some stuff down thinking, yeah, that's one. Yep, we see that too. And yeah, we agree with that. And of course, that's the problem too. But I think, just to kind of capture things generally as best as I possibly can, and to kind of keep in spirit of our summit theme, Why the Eye, I would definitely say that a general lack of public awareness about how intrinsic vision is and the role that it has in so many aspects of health and society and in our personal lives and as individuals. I think that's a major challenge in fostering access to care. Generally, the public, including lawmakers, and I'm constantly amazed when I talk to lawmakers and their staff on Capitol Hill, just how many people are like, oh, I didn't get glasses, or until I was in college, or, I had this condition as a child, but it wasn't detected until I was, in my adolescent years, or, the first time I had my vision checked was when I went to the DMV or something like that. Even they are saying, and it's reflecting this general lack of awareness about how the eye and its many underlying structures enable so many aspects of our daily lives, and just how consequential it is when a person experiences vision loss. As we know here at Prevent Blindness, many people who are most at risk of vision loss due to eye diseases like glaucoma, diabetic retinopathy, age-related macular degeneration, and so many other conditions are unaware of the damage that's occurring to the structures within their eye or the neural tissues that enable sight until changes to their vision occur. And even I, having been in my role here at Prevent Blindness for over 6 years, I'm still constantly learning about how all of these processes work together to enable our eyesight. And even last year during our advocacy event, Eyes on Capitol Hill, did I realize, because it was put to me this way, in a way that I could understand, that you could have glaucoma and also still have 20/20, which is considered normal visual acuity, and you may not know about it. So somebody who is in a situation like that is not going to seek that clinical eye care that is so important to making sure that they get into the system, they have that early intervention, that access to treatment, and ultimately that they have a good prognosis for their eyesight and can keep it as much as possible and manage that through their lifetime. So most of us, unless you start seeing things a little bit differently and you don't seek care until that happens, as we all know, by that point, it's most likely irreversible and damage has occurred. And so vision loss becomes permanent. So we really want to get to those people before something like that happens. But simply being aware, however, of your own risk for vision loss, that's really only part of the equation to preventing it from happening in the first place. We can put the information out, and we do a fantastic job of doing that. But for individuals, sometimes cost of care is often the very first barrier in access to receiving the vision and eye care treatment that they need. So a person might not have health coverage, they might not have vision insurance, or they might have some level of coverage, but it might be completely inadequate to address the needs that they have. There might be other things like co-pays or deductibles and some of those costs at the front. And even if those initial costs are affordable to the person and they can, pay their co-pays and their deductibles, or, they've saved up for an emergency of some kind, there's additional personal costs alongside of a vision loss or eye condition diagnosis. Things like needing frequent time off of work to access your treatments or to find an eye care provider that is close to you. Expending that time and energy to understand your condition and what that means for your life and what that's going to look like for your employment, for your family, all the things we've heard today in our summit. Lack of childcare to go to appointments, lack of transportation, especially if you depend on rideshare or if you need assistance from a loved one or a caregiver. All of those things can factor into that personal cost that becomes very burdensome to actually receiving eye care. And if you are a parent with more than one child with an eye condition, those costs can really add up very quickly. I think the same thing can be said that if you're facing several health conditions at once, each of those comes with their own costs and their own access challenges. And under these circumstances, we may see that a patient might not be able to prioritize their vision loss or their vision conditions simply because they're unable to. I think that there's also some barriers and challenges at the community level. And we see that excluding vision and eye health from health promotion efforts at the community level, where there's natural alignment with other issues, that can lead to misaligned goals and outcomes that can lead to costs that have potentially can compound over time. So that's really troublesome. One example I can think of here is that many healthy aging programs that exclude vision and eye health from conversations around falls prevention, cognitive decline, social isolation, and loneliness, or at the other end of the age spectrum, looking at children's vision and some of those fragmented national policies around access to children's vision and eye health. All of that can affect how a child develops and learns in school the longer that vision problem goes undetected. And so we see those things follow a child into their adult earning years, and that can be problematic as well. I'll close that by saying on a systems level, there's a lack of surveillance that truly captures both existing disease burden and the risk of vision loss, but also that measures the factors surrounding how individuals access eye care and what communities and public health departments and others, so many stakeholders across the vision spectrum need to truly address vision loss on the ground. And that can make it very difficult to address all of these other issues and barriers that I've just mentioned. And ultimately that can reduce access to care at the very end.
Outstanding. The next one's for you, Angela. I wanted to ask if there were any lessons learned or best practices or experiences that the vision community can take from other communities around integrating mental wellness and mental health care into their advocacy, into their work, and how we might kind of beg, borrow, and steal from each other?
That's such a great question. So I'll talk about the strategies around integration of care, and really one of them is advancing standards of care that include things like screenings and brief intervention and referral to care. SBIRT is one, which it actually literally stands for screening, brief intervention, and referral to treatment. It's focused around substance use, but there's the opportunity to do things like that for other mental health conditions as well. And what's beautiful about SBIRT is it's done in a primary care setting, can be done in specialty care settings, and it's really designed to ask a couple of very simple questions. And based on people's responses, it can trigger a little deeper dive. And one of the things research has found is that when somebody's treatment professional, physician, for example, talks about the use of substances that is higher than normal, that just talking to somebody about how their patterns of usage are beyond what the average person does has a really profound effect in terms of modifying people's behavior. And then, of course, if somebody really has more severe problems, being able to refer and follow up and get them into a treatment provider that's specialized is really profoundly important. So I would say borrowing on interventions like that work is something that can be done in settings like with vision professionals. I think there's a lot of opportunity there. Another thing I'd like to bring up is, really the Affordable Care Act years ago, when that was first introduced, had an increased rate for patient-centered primary care health homes that took certain steps to integrate behavioral health care. And that really changed clinics' behavior. I said before, if it's not paid for, it's not happening. When you have financial incentives, it can really change the behavior of professionals in terms of what they're able to ask for, what they screen for. So I think there's an opportunity here to work with the Centers for Medicare and Medicaid Services, CMMI, to create alternative payment methodologies for integrated vision and mental health care. I mean, that's definitely a possibility. Another strategy is I'd like to bring up, there are some medical professionals that are already integrating mental health pretty more commonly, I would say, into their practices. So we hear about a lot of endocrinologists and neurologists who frequently ask about a person's mental health at the same time, and understand, they may be asking about thyroid eye disease and your mental health at the same time. So this really suggests to me that there's both training and financial incentives that could be used to expand this approach to other specialists to really routinely be asking about people's mental health. Finally, I would mention that from a completely different, medical condition, diabetes, they've partnered with the CDC and really promoted public-private programs like the National Diabetes Prevention Program that really connects people to lifestyle changes that help address or prevent diabetes. And while that is not directly applicable, what I would say is I think there's a lot of opportunity to think more creatively about creating programs that help people get the help they need earlier. And one of the things that comes to mind is integrating telemental health and online cognitive behavioral therapy programs to really help people earlier and at less cost, much more on the front end before things get worse. So I think there are a lot of strategies here, and I think there's a unique opportunity, a point in time here to really work together and think about what might be most valuable for the community.
Excellent. Thank you so much. My next question really is kind of one that's very near and dear to my heart, as Sarah and others know. How do patient advocates and how have patient advocates created change in policy in your various areas? And how can they play an even bigger role in being good patient advocates and really driving and creating the change that they want to see? Um, Start with Sarah since Angela just went.
I'll let Angela catch her breath. Well, we've heard quite a few presentations just on the power of storytelling, and just telling those personal experiences, using data and research thoughtfully. So I'll always very highly endorse that approach. I used to be a Senate staffer myself, and I can tell you it's not, just telling you what you want to hear when I say that really those stories and those experiences that are connected to a policy are really the ones that stick in a lawmaker and a staffer's minds at the end of the day. And they're meeting with constituent and interest groups and representatives all day. So really at the end of the day, what you want is for your experience to stick because they're looking for ways that they can help. They're looking for things that they can give to their boss to do. And so when you're telling those stories, it's very important to keep that in mind that, they're getting pummeled left and right because there's lots of different issues and things to work on and all sorts of solutions to all sorts of problems. So when you're telling a story to a lawmaker, whether that's a personal experience or whether you're sharing something about your latest research or data points or just some troubling trends that you see, keep in mind that the person who's nodding their head and taking notes at the other end of the table, they're really listening for, what is this person asking me to do? What can I do on their behalf? Would my boss be interested in doing this? So when you tell those stories and use that information, do so in a way that compels a change with an outcome already in mind. So you want them to support legislation, increase funding to different programs, think creatively about some additional community-based strategies and other approaches that can work in their districts and their communities. Those are the kind of things that will not only get someone to say, yes, this is a problem, we should solve it, or we should do something about this, but are there other people who might be experiencing the same things, and is this something that we can do? So I'll always highly recommend that well thought out story that sort of creates that emotional resonance, but also uses those hard facts and information and kind of weaves everything in. That will definitely stick out in the minds of policymakers. I think too, I would also challenge vision advocates to think about this issue in a much broader context. Vision itself is a very broad issue. There's, all sorts of things can be attached to it. More colloquially, I was speaking with my colleagues about even some of the trends around vision loss and eye disease and, things that are related to natural disasters, which we're starting to see a lot more of those. Is there space for us at that table? Obviously, we're sitting here talking about where vision and eye health fits into mental health and mental well-being. So thinking about your issue and putting that into that bigger context will definitely open up a lot more opportunities to be able to identify what are some solutions to some problems and to help get your ideas at the table. I'd also say be open to learning about new ways that vision and eye health can be addressed through these other avenues, and know how to get on board when those opportunities arise. So when we see something like, hopefully we won't see another pandemic again, for goodness sake, but, when something like that did happen, back in the day, Prevent Blindness took sort of a 180 on our advocacy messaging to say, what are the implications for vision and eye health? What can we do? What are other organizations doing about this? Obviously, this is a big issue and everyone's got something going on with this. Where do we fit into this space? So looking at those things and, like I said, putting that into the larger context can really help move the needle on both the bigger issues, but also sort of the smaller ones. And on a final point to this question, you don't necessarily want to have your issue play second fiddle to something else, but you want to position yourself in a way that you know how to lead on your issue. You have the knowledge, you have the experience around it. You understand the implications and the consequences if it's not fully addressed, and also understand how to achieve your own goal by working through that other issue.
Outstanding, Angela.
Thank you for that. And Sarah, incredible response, just wonderful advice for all would-be advocates out there. So I'll just add a little different flavor to this, and really, because you touched on all the great points, I'll just say that in the mental health world, patient advocates have really been instrumental in transforming change. It wasn't that long ago that mental health used to be thought of as a character flaw or caused by cold, unloving mothers. Parents were blanked. It wasn't part of healthcare. It was perceived as being not treatable. And what treatment was available was often coercive and paternalistic and fatalistic. And today, mental health conditions are viewed as normal, treatable, manageable conditions, and something everyone at some point in their life is going to need. And it's patient voices, patient stories that have been key in changing those attitudes and changing that understanding. And that really is the precursor to changing policy and practice. And as Sara alluded to, policymakers really want to be the hero. They're inspired by people who've overcome adversity and who show them a path to make things easier for people to live better lives. And I'll give one example of this from the mental health world, and that is, when people leave hospitals, they get an experience of patient care survey from the hospital after they've left. But there are two populations of people who don't get that survey. Anybody with a primary diagnosis of a mental health condition or a substance use condition. And that is because of longstanding prejudices that prevented them from getting those survey responses from the get-go. So the survey was never actually developed or went through the statistical analysis to ensure that it is valid for people with mental health and substance use conditions. That sounds ridiculous today, but it created this huge barrier. And basically, the voices of people with mental health conditions simply aren't heard, not helping shape the experience of care. Well, recently there's been proposed rules to change that, and over 600 responses with people's experiences, heartbreaking, incredibly compelling, went to CMS. So that, coupled with meetings with leadership to discuss what's needed, has resulted in forward movement. So today there's a proposed rule to adopt required inpatient experience of care surveys for people with mental health and addictions. So the power of your stories is very real, and the collective power is truly transformational.
Absolutely. Amen to that. As somebody who's done this for years, you guys really hit the nail on the head. My next question is more specific. Are there policy opportunities that exist right now for the vision community and the mental health community to work together to help both? Angela, got any input there?
I'll just jump in. I'm thinking back to all the ways in which access to mental health care is limited or hindered, and ways to better integrate mental health care into primary and specialty care settings. I think those are areas in which the vision and mental health advocacy communities could really have a natural and powerful alignment. Inseparable, my organization, is focused on changing state and federal laws. We're not afraid of picking a fight with insurers, so we'd love to join forces. And really, I think there's something incredibly powerful and moving about groups coming together for a common cause that's really about lifting us all up and caring for each other and demanding that policy and practice do the same.
Absolutely. Sarah?
Yeah. Well, I think Angela and I sometimes joke. I've definitely said it before in the past. I think that, those of us who represent healthcare areas above the neck should create some sort of above the neck coalition. I think it's time. We're tenacious enough. Let's do it. But, I think, a lot of things that Angela's community is working on, and, a lot of the things that, those of us in the vision space are working on, they're not all that far apart. I know that there's a lot of, in the mental health community, getting to somebody early, getting them access to care, getting them to the system, putting it in primary care interventions. Those are all things that resonate with us in our space as well, too. There's been a lot of conversations today about what is the role of the provider, and simply getting a patient to talk about their condition. Are you okay? How are things going? What can I help you with? What sort of supports do you need? Those are all things that are very helpful, because a patient is just probably very overwhelmed when they receive a diagnosis that might change their life. I mean, they probably don't know what to think first. I think about this all the time. What would happen if I was in that situation? And I don't think I could do anything any different, but getting somebody to a support group and making sure that they have what they need to navigate this initial change in their lives, but also keeping that support long going, and not just, saying, okay, well, you're past your diagnosis, it's 6 months, it's 9 months, you might be good now, and I'm sure you've adapted. um, you know, there is that power of the human will and the spirit to adapt to circumstances, but none of us can do that by ourselves. And so making sure that there is that long-term support that is available to somebody who is facing a condition that loses their vision, and a lifestyle change and everything that comes with it, making sure that they are still doing okay, if they come in and continue to get treatments. Those are areas that our communities can work together on. Increasingly, we're learning a lot more about the burden of diseases and disease burnout. That definitely is something that is very real to a lot of patients in our community, especially those who might have diabetes or other conditions where you need to manage that ongoing. You might have a change in your circumstance that might make it a little bit difficult to continue accessing care. So making sure that those short and those long-term supports are in place, are definitely areas that our communities have alignment to. I was also jotting some notes down on specific things like telehealth and, working, to make sure that there's coverage for vision care and Medicare. I know that's always a very, very, pie in the sky sort of issue, but it's very real. Vision is, something that happens as we all age, and vision loss is, and prevent blindness continually challenges that doesn't have to be the case as long as those interventions are there. So learning from the mental health community about the work that they're doing with Medicare can most certainly help us achieve some of those goals too. And also certainly children and mental health. We tend to maybe think that mental health is something that, you sort of realize that there's issues, as you grow older, maybe you start realizing or processing things from your past as an adult. But there's also mental health needs for children as well too, especially with vision loss, especially if they have a rare condition where they might be facing progressive vision loss into their adult years. All of those supports are very well needed as well too. So looking at all the areas that our mental health colleagues are working on and finding those areas of symmetry, those are definitely ways that we can work together. And I look forward to that.
Absolutely. So wonderful to hear. Before we get to our last question, which is kind of a wrap up, there's a question in the Q&A I wanted to ask you. I thought you might have some thoughts on, Angela, given that your organization works both on the state and federal level. The issue of licensure of professionals across state lines is something we've confronted a lot, particularly during COVID and the advancements in telehealth and all of that. Somebody raised the issue that there is a lag for counselors and social workers and things like that to be acknowledged and licensed across state lines. Wondered if that was anything you've seen or had any thoughts about or were working on.
Yeah, that's such a good question. And I will just say that there are so many people that share your frustration in that. And honestly, the challenge is that state licensure laws are really on a state by state basis. And we do not have a nationalized healthcare system that allows for Congress to go in and basically mandate that to happen. Insurance coverage too is governed by multiple different entities from state to federal. So it's a challenging issue. However, there are licensure compacts, and there is the opportunity for advocates to really press on their, state legislators to join those licensure compacts and to press on them to do everything possible to break down the barriers that allow the care to follow the person. Because I think that's also one of the things we saw during the pandemic is people moved across state lines, then they lost contact with their preferred providers. That's not something that should happen. The care should follow the person.
Absolutely. All right. I'm going to wrap it up, and I'd like to ask each of you, kind of as a last hurrah, to take a minute and share with the group 2 to 3 things that you would like to share with them, either as next steps or key messages or takeaways that you want them to walk away with. So I'll start with you, Sarah.
Sure. I think the first thing I would say is, keep these conversations going. We saw it happen with mental health space. All of a sudden but somehow the narrative around it changed, and now it's becoming normalized. It's becoming more understood, and that's more on like a social level as well as an individual level. We're starting to just embrace our mental health much more. I would say the same thing about vision and eye health. It's difficult if you have never experienced this before to understand it, but it's so helpful for us who advocate in this space to know what you're going through and what you're experiencing and how that affects your life. These are things that we communicate to lawmakers on a daily basis. And so keep that information coming out. Please don't be afraid to tell your story, share your experience, whether as a professional, a caregiver, seeing somebody who experiences vision loss, or whether that's something that you've experienced yourself. Finally, to that, I would say stay involved. Prevent Blindness has brand new advocacy content on our website. It's advocacy.preventblindness.org. There's a wonderful place that you can sign up to receive advocacy alerts, reach out to your lawmakers to tell your story and your experiences, and stay informed on the issues and just how that impacts you as individuals and how it impacts your communities.
Wonderful. Angela?
All right. So first, never forget that your story is always right. It is your story. Tell it in a way that's concise and inspires hope, and you're going to motivate people to take action. Second, maybe takeaway is remember that what seems obvious to you and me is not always something that other people necessarily have ever thought about or realized. And assume good intent. Treat policymakers and even providers as though they would naturally want to improve the health and well-being of their constituents or patients, and offer them a way to be a hero by fixing flawed policies or practices. And with that, I'll turn it back over to you.
I love to hear that. Assume good intent is my own personal motto. That's how I try and live my life. So thank you both so much. I just wanted to express my appreciation personally. Also, I want to let people know that Sarah and Angela and I will be available for a Zoom chat for a half hour from 3:30 to 4, I believe. After this, the link is in the chat. And then we will now hand it over to, I'm just looking to see, there's one last question. It's about licensing. I think we've run out of time. I'm going to hand the microphone over now to Jeff Todd to give us a few closing remarks.
Thanks, Jennifer and Angela and Sarah. I was struck listening to your presentation, that so often we forget that the eye and brain exist within the same system, the nervous system, and there's so much that connects the two, and we need to continue to talk about this intersection between mental wellness and vision. So thank you for that. And before we wrap up, I did want to share some somewhat alarming news related to advocacy. Right now, as we speak, Congress is considering steep cuts and even elimination of core public health programs that have an impact on vision and eye health and the surrounding circumstances that lead to preventable vision loss. The CDC itself is looking at potential cuts close to $2 billion. Prevent Blindness continues to advocate to lawmakers about the vital role that federal funding has in promoting quality access to eye care and improving our national eye health, but we can't do this alone. Sarah shared earlier information about our advocacy efforts. We encourage you to visit our website at advocacy.preventblindness.org to learn more about this work, get involved, and sign up for advocacy alerts. Working together, we can hold some of this back. Thanks again for joining us today, everyone. And please know that all presentations and recordings from the summit are available on our website and our YouTube channel. You can stay up to date on all events, resources, and news that Prevent Blindness has to offer by subscribing to our e-newsletter, following us on social media, or navigating to our website. And finally, thanks to all the presenters and moderators for their time over the past 2 days. And thanks once again to our many sponsors without which we couldn't make this happen. And finally, thanks to all of you for joining in for our 12th year of this important discussion around vision and eye health. I hope to see you next year. Thanks a lot.